Assalamu alaikum, everyone. Am I audible?
Wa alaikum assalam. Yes, you are.
Welcome to the Neurosurgical Case Room. We are going to do the anatomy of frontal lobe. And since we missed a session yesterday, so I'll try compensating, doing an extra session tomorrow, inshallah. So without further ado, let's move. So we know frontal lobe is the largest lobe of the human brain, and the entire area, which is anterior to the central sulcus and superior to the lateral fissure, that the entire thing is the frontal lobe. But we divide it into certain areas with the help of gyri, so that we can identify important sulci, important regions which are eloquent and which we are in no position to compromise. But the anatomy is relatively very easy, especially after you people have done the Sylvian anatomy and the temporal lobe. Frontal lobe is relatively easy. I'm going to mark the gyri so that it's easier for you to follow visually. This is which sulcus is this?
Central sulcus.
That's right, this is central sulcus. And then which sulcus is this?
Superior frontal sulcus.
That's right. And then which one is this?
Inferior frontal sulcus.
Inferior frontal sulcus. So we have these two main sulci, especially on the superior and on the lateral surface of the frontal lobe. Let me write the names. Now, just anterior to the central sulcus, we have the pre-central gyrus, which we all know is the primary motor cortex. Write this. This is the primary motor area. And then we have all these vertical divisions. Just along the midline, along the interhemispheric fissure, the most medial portion, this is the superior frontal gyrus. Is it important or not? Is it important, superior frontal gyrus? Okay, we'll come back to the eloquence later on. Then this region between the superior frontal sulcus and the inferior frontal sulcus, we have this middle gyrus. This is the middle frontal gyrus. And then below the inferior frontal sulcus, we have the inferior frontal gyrus here. Inferior frontal gyrus is better viewed from the lateral surface. We have done its anatomy while we were doing the Sylvian fissure. But just so you know, it's better visible from the lateral side. Superior frontal gyrus is usually eloquent, especially if you're talking about the dominant region. Inferior frontal gyrus is also eloquent. You all know it is the Broca's area, especially the pars triangularis and the pars opercularis. Whereas middle frontal gyrus sometimes contain some eloquent areas, especially when we talk about the dominant lobe. It can have the frontal eye field, but this region is still safe enough to make a small corticectomy and access the basal ganglia in the depths of it. But if you have to choose a safer surgical corridor while you're choosing between all these anterior gyri, then a good option is to use this sulcus here. Let me change the color so that it's visible. This superior frontal sulcus, you can go transsulcal via this corridor so that you do not end up risking the frontal eye field. But otherwise, you can make a small corticectomy in middle frontal gyrus and access the basal ganglia. We use that corridor especially during the basal ganglia bleeds for evacuation without compromising any eloquent region. We clear all of this. Move. This is a cadaveric specimen, and the central sulcus, just anterior to central sulcus, we have the precentral gyrus, which is the primary motor cortex. Then you see the superior frontal gyrus as highlighted as the green, and the middle frontal gyrus, which is highlighted as the red. Am I audible?
Yes, you are.
Yes, you are.
Okay. I don't know. My Zoom is showing me the warnings of unstable internet connection. In the midline, what do we see? We see the interhemispheric fissure and also the medial surface of the frontal lobe, towards which we will come later on. Then you see the lateral surface, something which we are all very, very familiar with, especially because we have covered a lot about it during all these recent sessions. So let's look at it from the lateral view. This is the middle frontal gyrus. And this is the inferior frontal gyrus. Inferior frontal gyrus has these rami, which are extensions of sylvian fissure, anterior ascending and anterior horizontal rami. This is the posterior ramus of the sylvian fissure. We are not going to discuss it today. This here, where, let me clear so that there is some space. So this region is pars triangularis, pars opercularis, and these are Broca's area. We know this. And right below it, we have the anterior sylvian point, through which in the depths we can access the insula. And also this is the lateralmost localization of foramen of Monro. If you go directly in this direction, you are going to encounter foramen of Monro in the depths. So this anterior sylvian point is used as a location for insula and for the foramen of Monro along with MCA, but that has been discussed very, very thoroughly. So let's move to the other surfaces of the frontal lobe. Also, there was an important thing that I wanted to mention. In about 98% of the subjects, central sulcus does not meet sylvian fissure on the lateral surface of the brain. There usually is a small subcentral gyrus here. If you look closely, there is a small subcentral gyrus right around here, so it prevents meeting. There are 2% of people in which the central sulcus meets the sylvian fissure. Clear this and move. This is the inferior surface, and we did discuss inferior surface, the basal surface of the brain recently, because we were covering the sylvian fissure. But there are a few interesting structures here. The purple gyrus that you see marked is the gyrus rectus. I'll mark it on the other side as well, this yellow thing. This is the gyrus rectus. Please mute yourself. Okay, so we have the gyrus rectus here in the medialmost portion, and then there is a small sulcus, which if you look closely, it is visible right here, lateral to the gyrus rectus. This is the olfactory sulcus. Along with it, you will find the olfactory bulb and the olfactory tract. Let me draw here. This is the olfactory bulb and the tract, which is going posteriorly. Here we are going to have olfactory trigone and the stria somewhere around here. Lateral to this, we have these orbital gyri. Their classification we are going to see later on. So the medial surface of the inferior surface of the frontal lobe is also easy. There's nothing really difficult about it. Let's move to the medial surface. What you see here is the color-coded region. Let me draw again. These are the medialmost portions. And you know that since it is the medialmost portion, gyrus rectus is going to be here somewhere. And then the superior frontal gyrus also comes on the medial surface. This green region here, this is the medial continuation of superior frontal gyrus. So some authors name it as a separate gyrus, which is also called medial frontal gyrus. But there are other authors that say that this is just a medial continuation of superior frontal gyrus. There is no separate name for it. So it depends which anatomical textbook you're reading. Then, when we look at it posteriorly, you will see the central sulcus, and along with the central sulcus, we will also see the paracentral lobule. In fact, let me change the color So this thing here is the paracentral lobule. You see the central sulcus here. Posterior to the central sulcus, this is the primary sensory cortex. This is the primary motor cortex. And this here is the central sulcus. This entire thing is paracentral lobule. So paracentral lobule is a very important structure on the medial surface of the brain. And it is important to note that you cannot use this as a corridor without risking a neurological deficit in the patient. Posterior to it, there is precuneus, but let's not go there. It's part of the parietal lobe. Let me just write. This region is precuneus. And I was reminded of it because this is a non-eloquent corridor that we use. So there is another sulcus here, which follows the corpus callosum and its curvature. Can someone name this for me, please?
Cingulate sulcus.
That is cingulate sulcus. And below it, between the corpus callosum and the cingulate sulcus, we have this same named gyrus. We have the cingulate gyrus. Let me write it here. So this portion that you see, this is the cingulate gyrus. And then we have the cingulate sulcus on the medial surface. Are you all with me so far?
Yes, we are.
Thank you. So once we look under the cingulate sulcus and the cingulate gyrus, we see the corpus callosum. And because this is a cut section, you also see part of the lateral ventricle, but that is a discussion for another day. We move. Here you see the stripping of the cortex. Cortex has been stripped to expose the underlying white matter and important fibers. Let's name them. So this white portion here, we will discuss what fibers these are later on, but these white portions here are known as centrum semiovale. And since they have stripped it completely, you can also see these horizontal fibers, which are fibers of the corpus callosum connecting both the hemispheres. You cannot do the complete frontal lobe anatomy if you do not understand the underlying white matter fiber tracts, even though they are a separate topic. But I will try to cover at least a brief overview of these. You see that all the cortex has been stripped, and these small fibers, the ones that are marking here, that I am marking here in purple, they are the short association fibers. These are the short association fibers. Then you see that this is the temporal lobe, and there is this tract, white matter tract, that is going posteriorly. Temporal lobe, occipital lobe, it's going posteriorly, and it is connecting the temporal lobe and the occipital lobe. It's a white matter tract, inferior frontal occipital fasciculus or something. And then we have the uncinate fasciculus, which is really, really important. Why? Because it helps communicate the frontal lobe and the temporal lobe. And usually lesions around this region, for example, sphenoid wing meningiomas, etc., anything that is growing and disrupting this space can displace or compress this tract. And the communication between the frontal lobe and the temporal lobe can get compromised. Be clear so that we can come superiorly. Once you see the stripped down version of the frontal lobe, you see these longitudinal fibers here. And if you look very closely, even though the picture is slightly blurred, visible, so I'm going to draw it. There's a cut fiber which is going over here. So they are easy. I know all of you would be able to answer it. What are these longitudinal fibers? And what are the cut fibers? Can someone volunteer? No? They are easy. I think probably the picture is blurred. So the longitudinal fibers that you see here, I am audible, right?
Yes.
Okay, so these are corner radiata. Where do they originate from? We have these large motor cells, the cells of Benz or something, I don't remember the exact name. They are in the motor cortex, and they give off these long axons, which make up corona radiata, and these corona radiata then move down, converge, and form the internal capsule. If you look at this cut portion, it's the continuation of the same fiber tract from above. This is internal capsule. So from corona radiata, internal capsule. From internal capsule, it goes even deeper and forms the crest cerebri. We will have a separate session on these fibers, the association fibers, the projection fibers, the commissural fibers, because they are really, really important. But since we were covering the frontal lobe, I thought it's appropriate to include them. So we have the corona radiata, which are going down, making the internal capsule. Internal capsule goes even further down and then forms the crest cerebri. What you see here, I'll clear all of this. You can see putamen here as well. So we have the putamen, we have the internal capsule, and then we have the corpus callosum, which has been dissected and stripped off. And it is a horizontal fiber, so it's not really visible in this image. Are we all clear and on the same page?
Yes, ma'am.
Okay. Moving on.
Alhamdulillah. Alhamdulillah.
Keep yourself muted. So this is another decorticated image, decorticated cadaveric section where you see that the cortex has been stripped off and the longitudinal fibers of corona radiata are slightly better visible here. You can see these going here. You can see the U-shaped association fibers here. I'll change the color so that you do not end up confusing. These are the corona radiata fibers. There is another tract which goes here. This is superior longitudinal fasciculus, but it's not visible in this image because it has been cut down. Below it, you see corpus callosum here. And since that has been stripped down as well, you can see the lateral ventricle and the frontal horn of the lateral ventricle. Then you can see caudate, putamen, etc. These are the uncinate fasciculus, which is communicating the temporal lobe and the frontal lobe. Clear all of this. Now this is the medial surface. What they have done is they have only removed the corpus callosum. If you look at it, this small boundary here, this is corpus callosum, whose fibers have been cut and dissected. So you see the these orientation vertical fibers of the corona radiata, but you do not see the corpus callosum. So let's mark it here. So which portion is this? This is lateral ventricle, right? Here. The cavity is the lateral ventricle. What you're seeing at present is the wall of the lateral ventricle. You're seeing the caudate nucleus. This is the head of the caudate, and then it's going back like this. So this is caudate nucleus. You are looking at a wall of the lateral ventricle. If you follow this cavity, you will also see the atrium here posteriorly. And this is the frontal horn here. On the lateral surface, so this is all what we have discussed on the images so far. On the lateral surface, we have the precentral gyrus, which is the primary motor cortex. Then we have the superior frontal gyrus. We have the middle frontal gyrus, frontal eye fields, and but it is also used as a surgical entry point. Then we have the inferior frontal gyrus, which is divided into pars orbitalis, pars triangularis, and pars opercularis. On the medial surface, we have the medial frontal gyrus, which is a continuation of superior frontal gyrus. We have the cingulate gyrus, and we have the paracentral lobule, which is the medial continuation. Please keep yourself muted. I see a lot of new participants with us today, which is a good thing, but please keep yourself muted. It is really, really disruptive. I end up losing the train of my thought. So we have paracentral lobule, the medial continuation. We have precentral and the postcentral gyri, and we have discussed all of this so far. This we have also discussed on the images. Olfactory sulcus, medial to olfactory sulcus, we have gyrus rectus. Lateral to it, we have orbital gyri, and they are divided into anterior, posterior, medial, and lateral. I'm going to show you the pictures ahead. What you see here is a superior view where the operating surgeon has completely retracted the frontal lobe. So you are looking at the skull base while the frontal lobe has been retracted. You can see the olfactory bulb here. And here as well, you can also see the crista galli. This entire thing is the anterior skull base. So now keep this view because we are going to move ahead in the same region. In comparison with this, since this is a superior view, this is a lateral view. Frontal lobe has been retracted superiorly and sylvian fissure has been unsplitted so that you get such a good view. This is if you end up doing an orbitozygomatic craniotomy and you approach it from this slightly lateral view, and you retract the frontal lobe superiorly, you are going to look at this beautiful, beautiful image. This portion is the midline here. Always establish your orientation when you're looking at any dissection or any image. This is the midline. Olfactory tract. We have the olfactory bulb here. So this is the midline. And you see the carotid arteries. In fact, let's identify the anterior clinoidal process first. Just behind the anterior clinoidal process, you have the carotid artery, which is now intradural, and it is also in its terminal phase. It's going to bifurcate in ACA and MCA. You also see PCOM. So this is communicating segment. And you see anterior choroidal artery here. Along with that, if you look closely, posterior clinoidal process and cranial nerve 3. But you cannot have this view unless you have splitted open the sylvian fissure, because frontal lobe cannot be retracted as much as in this picture. Move. So what view is this? Can someone volunteer?
Superior?
Yes, this is a superior view. And if you look at it, midline is slightly towards this region. Always establish the orientation and the midline. This is the olfactory tract. This is the olfactory bulb here. You see the gyrus rectus. Let me mark it. See the gyrus rectus. So in this area, you're going to have interhemispheric fissure, where my purple margin is. Frontal lobe has been retracted superiorly, and anterior clinoidal process is visible here. Let me draw so that this is the ipsilateral anterior clinoidal process. This is on the other side, this is the contralateral. So this portion is going to be planomersphenoidal, understandably, right? Then if you are retracting it, you're going to see the carotid artery just from a different view. You're going to look at the carotid cistern. You see all these beautiful arachnoid membranes, and see PCOM, exiting from the carotid artery. And on this side, you see the carotid artery beautifully bifurcating in ACA and MCA. And you see ACA going towards the interhemispheric fissure, which we established that it's somewhere around here. Obviously, the anatomy will be slightly distorted because there has been extreme retraction going on. This is not a normal view that you will look at. Then you also see that pituitary stalk is here. And since pituitary stalk is here, optic chiasm is slightly posterior to its normal position. So this optic chiasm is a post-fixed chiasm. Is it clear? Am I audible, folks?
Yeah.
Yes, you are.
Frontal-
Excuse me, ma'am. I have a question. What's the significance of post-fixed chiasm?
Post-fixed chiasm is significant because let me go back. Let me go back and let's draw here. So imagine that this chiasm is post-fixed. What do you mean by post-fixed? What structure is going to get elongated and what structure is going to get shortened? Optic nerve is going to be longer than normal, right? Because for chiasm to go slightly posterior from its normal position, optic nerve has to be longer. So optic tracts are going to be slightly more posterior than their usual position. So what ends up happening here is if there's pituitary adenoma underneath it and it ends up growing superiorly, then that pituitary adenoma would be directly compressing this optic nerve here and here. It will not compress the chiasm because you look at it, where's the stalk? This here is the stalk. So if there is a tumor here, it's going to compress these. So the presentation is not going to be the typical bitemporal hemianopia you see. It might end up resulting in complete vision loss. It might end up resulting in only monocular vision loss and just a partial deficit of the other optic nerve. It will depend on the position of the tumor as well. But since chiasm is posterior, the typical bitemporal hemianopia that you see, it will not be a feature. But let's not go there. I think we have discussed this in the pituitary adenoma session as well. So let's move on. Let's come back to the basal surface of the frontal lobe. You see the gyrus rectus in the medialmost portion. We have the gyrus rectus here. This is the olfactory bulb, olfactory tract. This 3 portion here is the olfactory trigone. These here are the olfactory striae. And then we have the orbital gyri. If you look at it, let me see. I never seem to remember which is which. 7 is anterior. Medial is 8. Posterior is 9. And lateral is 10. So these are the orbital gyri. For us, they are not as much of a significance, but it is important to know the location. What ends up happening is, on the medial aspect of the superior frontal gyrus, we have the supplementary motor cortex. And if we end up manipulating here, we might risk having the global akinesia, speech deficit, and preserved motor pathways. So what is essentially going to happen is, let me write this, we have global akinesia, which means that the patient will not be able to initiate any movement, even if the power is intact. So the motor pathways are completely intact. There's nothing wrong with them, but the patient will not be able to initiate the movements. So that is called global akinesia. And this entire thing is also called akinetic mutism. A mutism in which the patient cannot move. So with speech deficit, If the dominant hemisphere is involved, patient might experience mutism or severe reduction in spontaneous speech. But strength is preserved. If you individually check the power and stuff, that is preserved. The long tract, and that is also completely preserved. The good thing about supplementary motor area syndrome is it is transient. It is temporary. Why? Because if there is injury on only one side, the other portion, the other side, the supplementary area is going to start compensating for it because there is neuroplasticity here. But it is going to take some time. For the contralateral SMA to work and to take over the work of the ipsilateral SMA, it is going to need some time, probably 3 to 4 months, to compensate the akinesia and the mutism. So if it ends up happening, you can always counsel the patient and the family that this is a transient effect. To visualize better, this exactly is the supplementary motor area. Remember, right here, this is the precentral sulcus and the central sulcus. This portion is the superior parietal lobule, somewhere around here. And if we end up disrupting this region, then patient has this SMA syndrome. Clear this? Why does it happen? It happens because there is this specific tract which is called frontal ascending tract. I was not aware of this. I got to know about this tract very, very recently. This is an oblique tract which connects the supplementary motor area with the inferior frontal gyrus. So it goes like this on the frontal lobe, both sides. I'm going to show you the pictures ahead. It's called a frontal ascending tract. The superior endpoint is the SMA. The inferior endpoint is the inferior frontal gyrus, which is the Broca's area specifically. Let's look at a few pictures. So you see that this is the superior frontal gyrus, this is the inferior frontal gyrus, and these are connected with an oblique tract, which is also called FAT or frontal ascending tract. This is a diffusion tensor imaging. This is a DTI, and you see the same tract obliquely placed around the most medial portion of the frontal lobe and the inferior frontal gyrus. This is the main reason a patient has SMA syndrome. And even if there is no surgical damage, if there is only structural damage, associated disorders, microscopic changes in this tract, they can lead to aphasia, they can lead to autism, stuttering, etc., etc. So we have the frontal operculum and the sylvian fissure. We have thoroughly covered this, so we are not going to spend much time on it today. Frontal operculum is part of the ceiling of the sylvian fissure, and we open it up to expose the insula and the MCA segments. Deep tracts we have already done. Then again, there is some difference of opinion. There are authors which count arcuate fasciculus as a subpart, as a portion of the superior longitudinal fasciculus. There are authors that say superior longitudinal fasciculus is very different from arcuate fasciculus. But for the sake of this discussion, we are going to consider it a part of the superior longitudinal fasciculus. It connects the frontal lobe with the temporal lobe. Then we have corona radiata, which are the descending motor fibers. We did them in thorough detail. And then we have the corpus callosum, which we will discuss in another session. You see some of the white matter tracts here. The red one is the inferior fronto-occipital fasciculus. It connects the frontal lobe and the occipital lobe. The yellow one is the uncinate fasciculus, and the green one is the inferior longitudinal fasciculus, which connects the temporal lobe and the occipital lobe. These are the diffusion tensor imaging, DTI and tractography, and if you look closely, you will understand how close the superior longitudinal fasciculus and the arcuate fasciculus are. The sky blue portion, this is sky blue portion. If you look at it, it's also coming down. This is the superior longitudinal fasciculus, whereas this purple portion here that I'm marking now with red, This is the arcuate fasciculus. So if you look at them, they are overlapping, and because they overlap, a lot of authors take them as parts of each other. Then we have the arterial supply, probably the easiest part of the entire session. ACA supplies the medial surface and the superior strip. Middle cerebral artery supplies majority of the lateral surface. We all know this, pretty basic anatomy. And you see a pictorial representation. This is the area of middle cerebral artery, this pink region on the medial surface, and on the lateral and superior surface, this region here is the anterior cerebral artery. On the coronal section, it's very clearly visualized. You see ACA, which is medial most, and you see MCA, which is covering the lateral portion. So can someone go over the homunculus very quickly? What structures are going to be here? Genitals, right? And
Lower limbs.
lower limbs. The foot,
Bladder.
the knee,
Bladder.
right?
Yes.
The foot, the knee, there's not enough space for me to draw here. The leg.
Bladder
So
also.
this, yes. And on the lateral side, we are going to have arm
And
and
this one.
face
This one.
and tongue, etc., etc. So what ends up happening is if AC is disrupted, the weakness is going to be more in the leg region. Whereas if MC is disrupted, the weakness is going to be brachiofacial. It's going to involve arm and the face. Clear this. Let's move on. This shows the overlapping supply of the deeper cortical structures. If you look at it, the purple region is the ACA territory, the sky blue region is the MCA territory. But when you look at the caudate and parts of the putamen, parts of the internal capsule, they are supplied by both the ACA and the MCA. There is an overlapping going on. These are supplied by the perforating arteries via the anterior perforating substance. And then there's a small yellow area here, which is the territory of anterior choroidal artery. Venous drainage is very simple. We have done this before when we were covering the temporal lobe. Superficial middle cerebral vein, the sylvian vein, which drains the inferior and the lateral aspects. This also drains the temporal lobe. But superiorly, the drainage is taken from vein of Trollard to the superior sagittal sinus. So vein of Trollard is the superior anastomotic vein. Vein of Labe is the inferior anastomotic vein. Vein of Trollard is the superior anastomotic vein. We look at it here. This is the superficial middle cerebral vein, which drains parts of the temporal lobe and also parts of the frontal lobe. And then we have the superior cerebral veins, which drain directly into superior sagittal sinus. And this here is the superior anastomotic vein, or the vein of Trollard, which connects this superficial middle cerebral vein to the superior sagittal vein, superior sagittal sinus. So that's a wrap. I'm sorry for the interruption between the session. Thank you so much for attending. Please leave me any questions or feedback if you have any on the WhatsApp group. We are very short on time, so I won't be able to take them live today. Thank you so much, everyone. This is a wrap.